Hello everyone. Welcome to today's specialty testing webinar on erythrocytosis. Our presenter today is Dr. James Hoyer, consultant in the Division of Hematopathology, professor of laboratory medicine and pathology, and co-director of the Metabolic Hematology Laboratory at Mayo Clinic in Rochester, Minnesota. Just a couple of things to remind everyone before we begin today. There will be a question and answer session at the end of the program. You can submit questions online via the chat function, or if you are participating in the audio-only portion of this webinar following the presentation, phone lines can be unmuted to ask a question. Today's program is also being recorded and will be posted to our website in a few weeks. And now I'll turn the phone over to our presenter. Thanks, Dr. Hoyer.
Thank you very much, and I'd like to extend a welcome to everybody listening in today. Here is my disclosure slide. I have nothing to disclose. Here's our objectives for this webinar that we'll be going through today. I plan to outline the causes of both hereditary and acquired erythrocytosis, but we will focus mainly on the causes of hereditary erythrocytosis and their pathogenesis. I will then discuss methods that are available to diagnose these disorders, and then present an algorithm that can aid in the workup of these patients. And then finally, I'll present a series of cases for illustration. But to begin, I did want to present a case first to have in the back of your mind as we go through our talk. This is a 52-year-old white male who was referred to Mayo Clinic for management of previously diagnosed polycythemia vera. This was discovered when he presented to his family physician in November of 2004 for evaluation of a lipoma of the shoulder. And I want to point out that date of 2004 is very important to keep in the back of your mind. And so as a part of the workup for this surgery, a CBC was done. And here is part of that CBC. And you can see that his hemoglobin and his hematocrit are very high for his age. And his white blood count and platelets, however, are within normal limits. He was referred to a local hematologist because of these CBC results. And at this time, the patient complained of mild fatigue, but no other symptoms, such as headaches, dizziness, pruritus, visual difficulties, or paresthesias. There was no history obtained of a bleeding or thrombotic event. And erythropoietin at this time was 12, which the lab that performed this is within their normal range. His physical examination was normal. Specifically, there was no hepatosplenomegaly. And his past medical history otherwise was significant only for an extensive smoking history of over 75 pack years. There was no cardiopulmonary disease. The hematologist was able to get a hold of his old medical records, and he noted that the patient had hematocrits into the 50s, sometimes as high as 59%, going back at least 20 years, so when he was in his 30s. He was diagnosed with polycythemia vera and begun on a program of weekly phlebotomies. This did bring his hematocrit down to 47.9 after 3 months, but there was no record of a bone marrow examination ever having been done. He presented then to Mayo Clinic for further treatment options for this disease in 2006. He still had no significant complaints. There was still no hepatosplenomegaly. And an erythropoietin level at this time was 71 with the ranges that were in effect here at Mayo at the time. And this is undoubtedly due to the fact that he's been having these phlebotomies. And at this point, a bone marrow examination was performed, and I'll show you a few slides. Here is the CBC that accompanied that bone marrow. You can see that his hemoglobin and hematocrit are down within normal ranges, but his red blood count is a little bit high. His white blood cells and platelets are still within normal limits. Here is the peripheral blood of that examination, basically just showing that it's normal. Here is a bone marrow. It looks a little dark to me, but if you can see basically that we see normal trilineage hematopoiesis, and here I'm pointing out 2 megakaryocytes, which are morphologically normal. There we go. Good. And here's the bone marrow biopsy. the white cells. For those of you who don't look at these, this is the fat in the bone marrow, and for a gentleman of 50 years, this is normal cellular for his age. And I'm pointing out here, these are megakaryocytes that are in the bone marrow, and you can see they are individually separated. They occur singly. There's no grouping. There is a reticulin stain, basically showing no increase in reticulin fibers. So in sum, this bone marrow was entirely normal. Chromosome studies that were done on this showed a normal 46XY karyotype. So the question to be asked is, does this gentleman really have polycythemia vera? And if not, what tests would be helpful to discover what he does have? So to begin also, let's talk about what is exactly erythrocytosis. If you look in Webster's dictionary, it says an increase in the total red blood cell mass, which is actually quite good. I want to point out that this is not really the same as polycythemia, although in the literature, unfortunately, these two terms are used interchangeably. Polycythemia more correctly refers to elevation in all cell lines, so the neutrophils and platelets as well. So how do we further define erythrocytosis? Well, a very simple way is simply to look at the patient's complete blood count. And here I've listed the hemoglobin and hematocrit. In parentheses here are the normal ranges that we have here at Mayo Clinic for males and females. A generally accepted level of 18.5 for males and 16.5 for females for the hemoglobin, and 52% and 48% respectively for the hematocrit is the definition of erythrocytosis, for example, by the WHO, the World Health Organization. As we look at patients with erythrocytosis, a very early and important question to ask is simply, how long has that erythrocytosis been present? If we can determine, based on looking at previous medical records, that it seems to have always been present, this would suggest that this is a hereditary cause of erythrocytosis. Conversely, if we can determine that this has developed later, in other words, we have an area where it has been documented that the CBC was normal and then the erythrocytosis developed later, this would suggest an acquired cause of erythrocytosis. Now here's a big list of things that can cause acquired erythrocytosis, and this is actually not even a complete list. And I won't have time today to dwell on these because of time constraints, but I do want to spend a little time talking about the first on this list, that is polycythemia vera, because that pertains to our first case. This is one of the chronic myeloproliferative disorders. The median age at diagnosis is 60 years. So in our gentleman, where it was first picked up in his 30s, that he had high red counts, it makes that unusual as well. There's a slight male predominance. The most characteristic feature of polycythemia vera is the erythrocytosis, but there can also be a neutrophilia and thrombocytosis, hence the term polycythemia. And the bone marrow typically shows a pan-hyperplasia, elevation of all three cell lines, and usually the megakaryocytes on the biopsy show clustering or groupings. Here is a bone marrow biopsy of a patient with polycythemia vera, and you can notice compared to the gentleman, the amount of white spaces, the fat, is much less. And then here in the center, you can see here is that grouping of megakaryocytes. And here as well, they are kind of forming little clusters. As many of you know, the JAK2 V617F mutation is now extremely important in the diagnosis of this disorder, polycythemia vera. This was first reported in 2005 by several groups independently. JAK2 refers to Janus kinase is the name of the gene. This is a tyrosine kinase associated with the erythropoietin receptor as well as other receptors. This kinase acts to phosphorylate specific tyrosine residues in the erythropoietin receptor. What this does then is it initiates several signaling cascades, with the end result that we get upregulation of many genes. Particularly important is one you may have heard of, the STAT5 pathway, standing for signal transducers and activation of transcription. The nomenclature, if you're not familiar, the V617F refers to a valine to phenylalanine amino acid substitution at position 617, and that is in exon 14 of the gene. This is in the pseudokinase region. It's not actually in the active site. This is a gain of function mutation. It likely causes loss of autoinhibition, in other words, the ability to shut down the signaling cascades when they are not needed. So what happens is we get continued upregulation of genes. And most important of all is that this mutation is found in 95% of cases of polycythemia vera. There are also now known to be mutations in a different exon, that is exon 12. These were first reported in 2007. These mutations are found in the V617F negative cases, so these are mutually exclusive. But these are also gain of function mutations, and there are over 20 different mutations that have been found to date. Most of these are short deletions. I can no better illustrate the impact or importance to these JAK2 mutations on the diagnosis of polycythemia vera than to look at the criteria that are used for this diagnosis pre and post JAK2. Here's the criteria from the 1990s that was developed by the polycythemia vera study group. And you can see there are a number of criteria. There are 5 major and 4 minor criteria. And to make the diagnosis, if you have A1 and A2 plus any other one in A, you could feel confident in your diagnosis. Or if you have A1 and A2 and any 2 in the B1s, notice here's the thrombocytosis and leukocytosis, you also could have the diagnosis. A problem with this always with some of these things in the major criteria, like performing a red blood cell mass study or this endogenous erythroid colony formation, was not really available to an awful lot of people. Here's the criteria per the WHO classification in 2008, in other words, post-JAK2. And you can see now we only have 2 major criteria and 3 minor criteria. If we have the hemoglobin levels, which we discussed, in the presence of the JAK2 or an exon 12 mutation, plus any one of these 3, you can have the diagnosis is confirmed. And of course, this test for the JAK2 V617F and the exon 12 are readily available to almost anybody to get. So it's greatly simplified the diagnosis of this disorder. In fact, now with the presence of a JAK2 mutation, the WHO has lowered this as a criteria down to 16.5 and 16 for males and females, the so-called masked polycythemia vera. If we look at the JAK2 V617F and the JAK2 exon 12, this accounts for virtually all of the cases of PV. So the most important test, and I can't emphasize this enough, the most important test to do in any case of erythrocytosis, first and foremost, is the JAK2 V617F test. Even if your history indicates this is likely a congenital or inherited cause of erythrocytosis, it's still very important, given the implications of polycythemia vera, to just make sure that this is negative. The other thing that this has done that we found in our lab is it's created an increased awareness of these hereditary causes, because clinicians, if they get a negative JAK2 V617F and a exon 12 being negative, they say, okay, well, if this isn't polycythemia vera, what is it? And they're actually very interested into determining what is the underlying cause. So going back to our big table on acquired erythrocytosis, I just want to point out that if you look at the items on this list, talking about cardiac and renal or tumor-associated, with a good history and physical, a good examination, maybe some supportive testing, you should have a pretty good idea with most of the things on this list what might be causing the erythrocytosis, or the erythrocytosis is a manifestation of one of these diseases. Now here is a list of the hereditary causes of erythrocytosis as we know them today. And these are the ones I'll be talking about today. I will not talk about the methemoglobin disorders because even though these are associated with erythrocytosis, the clinical symptom, the clinical picture is dominated by the cyanosis that it is present. So that's the main feature of these. And then the bisphosphoglycerate mutase, I will not talk about because it's so exceedingly rare. Basically, this is the enzyme that produces 2,3-DPG, and if you don't have 2,3-DPG, your oxygen dissociation curve markedly shifts to the left. But let's start then with high oxygen affinity hemoglobin variants. So why do these high oxygen affinity variants cause erythrocytosis? What happens is the affinity of the hemoglobin molecule for oxygen is altered. As the name implies, it has a higher affinity, it binds tighter than normal. So if it binds tighter, it also doesn't release as readily. There are several different mechanisms how this happens, but the most common is the amino acid that we have, the substitution occurs at a very critical area, and that is the area where the globin chains touch. There are weak bonds that keep these together, and that's called the alpha-beta interface. So because of this tight binding, oxygen delivered to tissues is reduced. The kidney senses this as, in essence, a hypoxic situation, responds by producing erythropoietin, which then stimulates production of more red blood cells. So with the increased mass, there comes a point where it is not felt to be hypoxic anymore. So this feedback mechanism is shut down. So these patients really have an equilibrium that's just higher than normal. Their normal set point is, say, at 18.5, where others would be much lower than that. Here is a diagram off to the left here of the hemoglobin tetramer. Remember, 2 alphas, 2 betas, a total of 4 subunits, and I've circled here these areas where the hemoglobin molecules touch. And the conformation of this hemoglobin molecule does change right along those interfaces, just making it more easy to acquire oxygen as the molecule starts to become oxygenated. Very important in the work of high oxygen variants is the oxygen dissociation curve. Remember, what we're plotting is the partial pressure of oxygen against the percent saturation of the hemoglobin molecule. And you can see here on the control, this is the normal control, a very characteristic classic sigmoidal or S-shaped configuration. And over here is the high oxygen affinity variant, once again flattening what's called a hyperbolic curve to it. And you can see it shifts over this way. It's called the left shift of the oxygen dissociation curve. A convenient way to express this oxygen dissociation curve is what's called the P50, or that is the partial pressure of oxygen where the molecule is 50% saturated. And you can see here we would have a P50 in these high oxygen affinity variants that would be lower. It's typically down in the teens. It is typically beta chain variants that cause the clinical symptoms, in other words, the erythrocytosis. That's because everybody has 2 beta genes and 4 alpha genes. So if we have an abnormality in the beta genes, 1 beta gene, it's going to cause 50% of our molecules to have the high oxygen affinity subunit, whereas for alphas, it's only 1 out of 4. And I mentioned the oxygen dissociation curve is very important in the work of these because it's always left shifted. As I mentioned, the P50 is in the mid-teens. And the reason for this is because, unfortunately, these variants can be electrophoretically silent. In other words, we can't see them as a separate. And this is due to what's called a neutral charge substitution. What happens there is if we have a nucleotide change in our DNA that now codes for another amino acid, if that new amino acid, let's say it's negatively charged, has the exact same side chain charge as the one it's replacing, it doesn't alter the overall charge of the hemoglobin molecule. And unfortunately, the way we use our methods, hemoglobin electrophoresis or high performance liquid chromatography, is based on that charge difference as the way to separate out hemoglobin variants from normal hemoglobin A. So simply we just won't see that on our methods. Getting back to the critical need for the oxygen dissociation curve, because even if we don't see a hemoglobin variant, but we have an altered left-shifted oxygen dissociation curve, we would need to confirm this by molecular methods. So you can see that a high index of suspicion is necessary. A negative hemoglobin electrophoresis result without performing the oxygen dissociation curve is not sufficient. To give you an example, here's one that we have seen multiple times. It's called hemoglobin San Diego. And you can see here, these are two of the most popular screening methods used by laboratories: high-performance liquid chromatography and capillary electrophoresis. You can see on each one, this is the normal hemoglobin A peak on both. Here's the A2 peak, and you see no other peaks. So even though the variant is present, we can't see it. When I made this slide looking at the hemoglobin database, what's called HBVAR, there are 146 high oxygen affinity beta chain variants that have been described and 63 alpha chain variants. The reason probably that there are less alpha chains is they don't cause quite the symptomatology of the erythrocytosis as the betas, and so may not come to clinical attention. And these are inherited in an autosomal dominant fashion, meaning we only need to have one hit to produce symptoms. Let's turn now to erythropoietin receptor mutations. Here's a diagram of erythropoietin and its receptor. I will point out right here. Here's where the JAK2/6 sits in the intracellular domain. When erythropoietin, the ligand, combines with the receptor, these two parts of it come together, or what's called dimerization. JAK2 actually autophosphorylates itself, and then, as we talked about, initiates phosphorylation of all these tyrosine residues on all these different signaling pathways. Here's the STAT5, with the end result is that these now upregulate these genes that are involved in cellular proliferation. Some of these actually are negative regulators, like SHIP1. In other words, they act to shut this whole signaling cascade down when it's not needed. When we have erythropoietin receptor mutations, they all have in common that they are truncation mutations, such as due to a frame shift or an abnormal stop codon. And what happens is we lose this portion of the intracellular domain. The STAT5 pathway remains, but things like SHIP1 are now deleted. So now we get unopposed regulation or upregulation of pathways like the STAT5, so increased transcription of these genes. As I mentioned, the majority of these are truncation mutations, all conveniently located in exon 8. We lose that cytoplasmic intracellular domain, which loses the negative regulatory region. For these disorders, the EPO levels are characteristically extremely low, just as they are in polycythemia vera. So these EPO-R mutations are the only cause of a primary hereditary erythrocytosis. And what I mean by that is production of the erythroid precursors is not stimulated by high erythropoietin levels. So there are two causes of primary erythrocytosis. There's the hereditary cause, the EPO-R mutations, and the acquired cause, which is polycythemia vera. And the mechanisms of both of these are similar. They both involve the same receptor, and they both have loss of autoinhibition. Let's turn then to mutations in the oxygen sensing pathway. And to look at these mutations, it's helpful to review how this pathway works. And this pathway is present not just in red cells, it's present in all cells in the body, at least all cells with still have a nucleus. And there are three key proteins involved. The first is what's called HIF-alpha, the hypoxia-inducible factor. This protein will bind to a DNA sequence. It has to be with its HIF-beta subunit. And what happens is that it increases transcription of whatever gene it's bind to. One of these would be, for example, the erythropoietin gene. The next protein is the PHD2, or prolyl hydroxylase domain protein. This is actually an enzyme. It hydroxylates proline amino acids. Importantly, though, oxygen must be present for this to occur. And the final protein is the von Hippel-Lindau protein, which binds to the HIF-alpha. And if it successfully does this, it causes destruction of the HIF-alpha by proteasomes. So here's a nice diagram illustrating all that. Excuse me. Off to the left, we have the normal situation where we have abundant oxygen. You can see that's illustrated by little molecules. In this situation, we get binding of the PhD molecule to the HIF with oxygen present. Here are these prolines that are illustrated. These are hydroxylated. This is actually the signal for the VHL to bind. This is the recognition signal that it binds. When this is all successful, you can see here's the ubiquitins here that are going to degrade this HIF alpha subunit. So when it's degraded, then it cannot combine with its HIF beta subunit, and we can't get upregulation of these genes. Now, when there's not enough oxygen around, PHD2 can bind, but it can't hydroxylate effectively. Therefore, the VHL cannot bind. The HIF alpha, as shown here, persists. Now it does bind to its HIF beta subunit, attaches to target genes, and we get upregulated of the target genes. And just a blow-up of that diagram showing here, the two key prolines in this process is one proline 405 and 531. We can summarize these mutations in a sense by saying that a mutation in any one of these proteins may prevent the normal functioning of this pathway, with the end result of all being that the HIF alpha subunit is not degraded. What this does then is creates a hypoxia-like situation, with the end result being that we have production of more red blood cells. So let's look individually at the three proteins. The key one is HIF2 alpha. There are more than one HIF. For red blood cells, it's the HIF2. The gene, more correctly, is known as EPAS1. This is inherited in an autosomal dominant inheritance pattern. In other words, only one hit is needed. In these, the erythropoietin levels are normal or high. And these have been all missense mutations in exon 12, which is the location of the proline 531. Very recently, some groups have been starting to report mutations in exon 9, which is where the proline 405 is located. When we get an amino acid substitution, it acts to interfere with PHD2's ability to hydroxylate the proline 531. The end result being that the VHL does not successfully bind to the HIF2 alpha, and the HIF2 alpha then is not degraded. PHD2, once again, more than one PhD. For our purposes, it's the PHD2 or EGLN1 mutations of gene here. Also an autosomal dominant inheritance pattern. EPO levels are usually within normal range. There are several different types of mutations that have been described. The common theme, however, is we get disruption of the PHD2 catalytic domain. Therefore, it cannot hydroxylate the prolines, and we don't get VHL binding. We don't get destruction of the HIF alpha subunit. And finally, VHL mutations. Conversely, this is inherited in an autosomal recessive inheritance pattern. There is a well-recognized, and it's been recognized for quite some time, disorder called Chuvash polycythemia. It's an endemic erythrocytosis in a specific area of Russia. And we now know with the advent of molecular testing that patients that have this Chuvash polycythemia are homozygous for this mutation in the VHL gene, an R200W or arginine to tryptophan mutation. These cases are notable for very markedly elevated EPO levels. Since that time, we have identified other missense mutations in the VHL gene. So we now have compound heterozygotes, but there's still one of the mutations is always the R200W. Now the pathogenesis of these is not very well described at this point, but it is clear that the abnormality in the VHL protein must somehow prevent its binding to the HIF alpha and then the destruction of the HIF alpha. Some of you may know of the von Hippel-Lindau syndrome. occurring in the same gene. And it's interesting that if we look at the two, even though they involve the same gene, the symptoms are different. You can see that here in Chuvash, it's dominated by the erythrocytosis. That characteristic does not occur in von Hippel-Lindau syndrome, in which the major manifestation is the multiple malignant tumors. You can see that the R200W does not occur in von Hippel-Lindau syndrome like it does in Chuvash. In fact, quite a few of these are large deletions. And there's often a second hit in the tumor. Interestingly, these are usually mutually exclusive, so either you have the Chuvash or the von Hippel-Lindau. Patients almost never have both. So it has been not too difficult to develop molecular methods to evaluate these disorders that I've described. And that's for one of two reasons. The first is that these genes are, fortunately, many of them are rather small, so we can just sequence the entire gene, or the mutations are conveniently confined to specific regions of the gene, so we only have to look in a specific exon. So we've been able, and others have been able, to easily develop these methods to identify these mutations. And here they are. We can use DNA or Sanger sequencing, simple Sanger sequencing, for all of these disorders. You can see here for the globin genes, there were only 3 exons to each of these, and so we just sequenced the whole gene. As we talked about with the EPO-R, we only need to look in exon 8. That is the location of all of these truncation mutations. PHD2 consists of only 5 exons, so we can just sequence the whole thing. For the HIF2, as I've described, almost all of them are in exon 12, with a few in exon 9, so we only need to look in these 2 areas. And then once again, with the VHL, 3 exons, so we just sequence all of them. And now there's an algorithm that's available that can be helpful in the workup of these patients. And here it is. You can see this was first published by Drs. Patnick and Teferi, 2 of the clinical hematologists here at Mayo. And this doesn't really work as necessarily a testing algorithm, as I'll talk about later, but it's still a nice flow chart that helps you stratify and work through how testing helps in identifying these patients. There are 2 critical points in this algorithm. The first of these is at the very top. As we talked about before, doing the JAK2 V617F is the most important initial test. Also doing the serum EPO, because if this is positive, and pretty much probably with other things, you can confirm the diagnosis of PVERA. Talking about the testing not fitting this algorithm, through Mayo Med Labs now, there's through our molecular heme lab, there's a reflex that you can get that you can order the JAK2 V617F and the exon 12 mutations together, and so if it's V617F negative, it will automatically reflex to the exon 12. So you can see that doesn't really follow this flow chart. But the other key branch point is right here, the P50. And particularly as we get down, you can see the hereditary causes. It pretty much splits it, helps us very much to decide whether we want to go down the oxygen sensing pathway or to the high oxygen affinity variants. So let's now return to our case I presented earlier, the 52-year-old male. Once again, here's his hemoglobin. You can see he's microcytic with a little bit of a high RDW. Once again, this is likely iron deficiency due to the phlebotomies he's gotten. Now, as he presents to Mayo in 2006, the JAK2 V617F test is now available and was negative. Here again is his serum erythropoietin, once again high because of the phlebotomies he's gotten. So you can see here we're going down this tree, this side of the pathway. We have history from the hematologist that suggests this is a lifelong erythrocytosis, so the next key is to do the P50. And you can see here is his oxygen dissociation curve indicated here, having that characteristic hyperbolic shape with a P50 of 12. But here are his hemoglobin screening studies. You can see the A, peak, A2. We do not see a hemoglobin variant here, but because, once again, we have the abnormal P50, it is necessary to go and do DNA sequencing. And here's a portion of that sequencing done on an ABI automated sequencer, and here's basically the DNA sequence being read all along here. And I've oriented you based on the codons above, and you can see what the arrow is pointing to. There are two signals here indicating we have a normal and an abnormal nucleotide here in codon 109. This is a GTG to ATG substitution at the 109th codon of the beta gene. And this is a valine to methionine substitution, or in other words, our friend that we've already talked about, hemoglobin San Diego. So this is, in fact, erythrocytosis due to hemoglobin San Diego, a high oxygen affinity hemoglobin variant. He does not have polycythemia vera. I would say over the years, in particular before the discovery of the JAK2 V617F mutation, we have seen a number of these patients like this that were given a diagnosis of polycythemia vera, even though really looking back critically at his history did not in any way suggest that he might have this disorder. For example, the age was highly unusual for having this disorder. Our next case, this is a 12-year-old American girl who is of Spanish heritage, and her erythrocytosis was first noted on a 10-month well baby exam. Here's her hemoglobins of range from 15 to 20. For her age, this would be the normal range. She feels great. She has no symptoms. There's, interestingly, no known family history of erythrocytosis. She has no cardiac or pulmonary disorders. At the time we evaluated her, here's her CBC, a markedly elevated hemoglobin and hematocrit, as well as red count. Notice as well, though, that her white blood cell count and platelets are normal. Here's the testing. The JAK2 V617F and exons 12 through 14 were done at the same time and are both negative. Here's our serum EPO, which was within normal limits. So we are going down, once again, the right branch of our flow chart here. We have a strong history that suggests that this is a lifelong or inherited erythrocytosis. The next step is to do the P50. So you can see this is within normal limits. So we would be thinking of going down the branch here, looking at the oxygen sensing pathway. And here is the results of that. PHD2 is normal, VHL is normal. We have a substitution here at position 1601, a C to G nucleotide substitution, producing a proline to arginine substitution at 534. Notice that this is very close to 531. So she has erythrocytosis due to a mutation in exon 12 of the HIF2 alpha gene. This is a pathogenic mutation that has been published in the literature. As we talked about before, this amino acid substitution, being that it's so close to the proline 531, interferes with the ability of PHD2 to hydroxylate that proline. So the VHL protein cannot bind. So the HIF2 alpha is not destroyed. It combines with its beta subunit, and we get upregulation of genes, particularly erythropoietin. Once again, the blow up of our chart showing here is the prolines 405 and 531. On to case 3. An 18-year-old white male comes in for evaluation of, and I put it in quotes, polycythemia vera. Unfortunately, this case is actually post-JAK2 era, so it should be really highly suspicious that an 18-year-old would not have a diagnosis of polycythemia vera, particularly when he was first noted to have an elevated hemoglobin at 11 months of age. He does undergo periodic phlebotomies about every 4 to 6 weeks. He has no cardiopulmonary disease. He has no thrombotic events. Him as well, he has no other family members affected that is known. His only complaint is occasional sharp chest pain, And on his physical examination, there is mild splenomegaly. Because of his previous history, or he's been given the diagnosis of polycythemia vera, a bone marrow was performed. Here is the CBC results that are concurrent with that bone marrow. You can see his hemoglobin hematocrit or within normal range. Has a very high red count and is very microcytic. This is due to the fact that he is now iron deficient because of his phlebotomies. Here's some slides of that bone marrow, the peripheral blood, showing that there are hypochromic cells with some elliptocytes here due to his iron deficiency. On his aspirate, his hematopoiesis looks normal. Here is his bone marrow, very cellular, but he's only 18. So really this is, for a male of his age, really normal cellular, perhaps just a little bit hypercellular. But once again, you can see I'm pointing out the megakaryocytes here, and they are all located singly. They are not forming the groupings. Here is his JAK2 V617F and exon 12 to 14 sequencing. Both are negative. His serum erythropoietin is very, very high, sky high actually. And once again, his ferritin is very low. He is iron deficient. So we are once again going down this avenue here. It does appear strongly that this is a lifelong erythrocytosis. We would next do the P50. You can see here, here's the patient. He's actually a little bit right shifted compared to the control, but it still falls within our normal range for a normal P50 value. So we would once again be looking at the oxygen sensing pathway. His PHD2 is normal as HIF2, but he has two different mutations in the VHL gene. I point out here's the classic R200W, and he has another mutation that is known to be pathogenic. So he has erythrocytosis due to compound heterozygosity for two different VHL mutations, one of which is a classic QVASH mutation. And the abnormality in the VHL protein, once again, same common pathogenesis, prevents binding to the HIF2 alpha, which persists and binds to its HIF beta subunit. So that high erythropoietin is characteristic of these type of patients. And the final case that I will present is a 69-year-old Caucasian female, and you can see she has a 44-year history of polycythemia vera. I put the exclamation point because this is would be really unheard of to have that long of a disease course for this disease. She was noted to have a high hemoglobin during pregnancy with her daughter. I believe she was in her 20s then when that happened. She has been undergoing phlebotomies every 4 to 6 weeks for over 40 years, and she's been followed by several doctors. 20 years ago, she had a bone marrow examination, which was diagnostic for polycythemia vera. Unfortunately, we were not able to review these slides. However, 2 years ago, a JAK2 V617F test was done and was negative, so she now comes to Mayo Clinic for further evaluation. Here is her CBC at the time of this visit. You can see here hemoglobin within normal range, hematocrit a little bit high, platelets and WBC normal. Her only symptom was what's called aquagenic pruritus. This is intense itching after bathing, which is unfortunate in the sense because this is one of the classic symptoms of patients with polycythemia vera. Any water just causes extremely intense itching. This may actually have been the reason why she was given that diagnosis a long time ago, as this symptomatology has been present the whole time. She has no cardiopulmonary disease. She has no splenomegaly on physical examination. Because of this prior diagnosis, I'm sure perhaps because of this symptom and a long history, the bone marrow examination was repeated. You can see here the peripheral blood looks entirely normal on the bone marrow aspirate here on the right. Normal appearing red and white blood cells or precursors. Here is her bone marrow biopsy. For her age, there is a lot more fat here, but for this age, this is normal. Once again, here are the megakaryocytes, not too many of them actually, interspersed. There's another one with no clustering. So once again, the bone marrow examination was normal. I don't have it on the slide here, but her cytogenetics were normal too. So testing was begun for hereditary erythrocytosis. The JAK2 V617F was repeated, was negative. Exon 12 to 14 sequencing was also done and was negative. Very interestingly, her serum EPO was extremely low. Once again, this as well, if somebody had done an EPO a while ago, this might as well, because this is characteristic of P. vera, but this might have been another reason why the diagnosis was still considered correct. Here's her P50. I won't show the slide, but it was within normal limits. So interestingly, we are over here. We know she's exon 12. So far, the flow chart would suggest that she might have an erythropoietin receptor mutation. And in fact, she does. When we sequenced the EPO-R gene in exon 8, she has this 316G-A, or tryptophan. The X means that we have a basically premature stop codon where you get truncation of the EPO protein in the typical mechanism that we usually see. Once again, this results in loss of the cytoplasmic domain, deletion of those negative regulatory elements. So she has erythrocytosis due to a mutation in the erythropoietin receptor gene. This is actually, in a sense, it's a highly interesting mutation. It's well documented in the literature. And in some sense, it's famous because this paper indicates this was the very first mutation that was published documenting these EPO-R receptor mutations. And this was first found in a gentleman that actually, he was Finnish, and he was a fairly successful cross-country skier. He won several Olympic gold medals, including 3 medals. And the story was that he was always accused of cheating because when he had a CBC, his red blood count and his hemoglobin were very high, and he always steadfastly maintained, no, he was not a cheater, and he was subsequently shown to be right. So here's our experience with these hereditary erythrocytosis mutations. We have been looking for high oxygen affinity variants for quite a long time, even before we had molecular testing, so that we have the most experience in those. Since November of 2012, we have had up and running the mutations for the other genes that we've talked about. And here's a summary of what we found at the time I made this slide. Dr. Oliveira, my co-director in the lab, is in the process. We've got a paper in submission updating our results with these, but you can see we have seen patients with mutations in all of the pathways that I've talked about today. Here's a list of our hemoglobin variants. The one we've seen most is hemoglobin Malmo. Here's hemoglobin San Diego that we talked about earlier, but we've seen a whole bunch of them that maybe we've seen only once or twice. So to summarize, many of the causes of erythrocytosis have been discovered. We still have genes. We still have things to be discovered, though. I highlight here a paper from the European Journal of Hematology. This is from the Portuguese group in 2013. They had 70 patients in which they did a pretty good job of eliminating causes of acquired erythrocytosis. And yet, when they studied these patients, they've only found the cause in about half of the cases. So are there things out there that are yet to be discovered? You may be asking yourself, if I have a patient like this that has this erythrocytosis, can I order the testing? And the answer is yes. All of this is available that we've talked about today is available through Mayo Med Labs. The easiest way is to do what we call the REVE, the erythrocytosis evaluation. It potentially includes all the things on this list. If you want, you can order these individually. Almost all these components can be ordered individually. For example, this hemp, it's this cluster of things here that are ordered. This gets back to what I was talking about, where it's not actually following that algorithm. If you order the hemp panel, you get HIF2 alpha, PHD2, and the EPO-R. Those are all clustered together. And the VHL is not part of that group because of the von Hippel-Lindau syndrome. This testing had already been available through the endocrine lab for von Hippel-Lindau, and it seemed to us, we work with the endocrine lab to order this up rather than develop a duplicate test, which would cause confusion. We just simply will reflex to them. So we will actually, in the algorithm, do these, and if these are all negative, we will reflex to the VHL. And the last thing we always do, because it's so rare, is the enzyme or do sequencing for the BPGM gene. So this is a more simplified algorithm, which I believe is present on the MML website, emphasizes the importance of doing the the JAK2 testing and a serum EPO. If either one of these are positive, you're down in the polycythemia vera. It's only when your JAK2 testing is negative that you start to enter down in all the testing here that is available through the erythrocytosis evaluation. I believe that is my last slide. Thank you very much for listening in today.
Thank you, Dr. Hoyer. At this time, we would like to take any questions that you may have. If you would like to ask a question, please submit through the chat function on the CenturyLink web application. For participants joining in the audio-only portion of this webinar, press *7 to unmute your phone. And once you have finished asking your question, press *6 to mute your line again. So we do have one question that was already submitted through the chat function. It said, if the JAK2 V617F mutation percentage is just trace amounts, less than 1%, is that still considered positive?
That's a very excellent question, and I would say you have to be extremely careful with that low allele burden. You have to put it together. You would need to do a bone marrow. You would need to correlate that with the patient's history, but I would definitely agree, beware of that. I actually had an additional case that I deleted because of time constraints, but it was a case of a patient just like this with an extremely low allele burden. It was a patient seen at Mayo Scottsdale. The hematologist did not think that this was polycythemia based on a very benign history. In other words, no symptoms. He had had it for a while. He did a bone marrow examination. It was normal. We subsequently did all our testing, and he actually had a high oxygen affinity variant, hemoglobin Olympia. So the answer is just be very, very careful with a low allele burden. And I think what they might do is follow that patient if the allele burden goes up at a later time. But I don't think you can use that. And that's usually the way those are signed out, at least through here. There are specific comments that talk about that. That be careful when it's very, very small. It does not actually mean absolutely that it's P. vera or one of the other chronic myeloproliferative disorders.
The second question is your erythrocytosis evaluation sequential, or do you always perform all tests?
No, we do not always perform all tests. It is a sequential. Maybe I can go back. Our feeling is, as we have gathered data, and with one of these patients, these are all rare things, but the thing we have seen the most is the high oxygen affinity variant. So as we get it, and I would emphasize that as testing comes to our laboratory, we assume that the JAK2 tests are negative. We hope that we are not doing all this testing on a patient that subsequently is found to have polycythemia vera. So the first things that are done are the P50 and the hemoglobin electrophoresis. If we would happen to find a high oxygen variant, we stop. We don't do any of the other testing. If those are negative, then we will go down and do the erythrocyte, the hemp test, basically, is the next thing. If something's found there, we do not progress. So we try to do this. It is done in a sequential fashion. As I mentioned, it doesn't really follow that algorithm or flow chart, but it is still designed to try to do it in an efficient manner.
Okay. Next question. Do patients with hereditary erythrocytosis benefit from drugs such as ruxolitinib? I probably did not pronounce it right. My apologies. And are they necessary with high HCT and HGB?
As far as I know, I have not heard anything that they are treated that way. If these patients are ever treated at all, they are treated with phlebotomy, but there is debate about that, whether you need to. As I mentioned with the high oxygen affinity variants in particular, if you phlebotomize them, that's going to actually kick in the whole system, the erythropoietin, like in the first gentleman. It's going to be high. They are going to continue to try to get back up to that set point, back up to where they normally live at that high hemoglobin. So there is debate whether that helps them at all. The idea might be just leave them alone, even though people have a problem because of polycythemia vera. There's always a knee-jerk reaction to phlebotomize these patients to get that hemoglobin down into the normal range, but there's debate whether that even needs to be done. It seems that some patients symptomatically, if they have, say, some patients seem to have headaches and they feel much better with the phlebotomy. If symptomatically they do, it seems okay to do that. But other than that, that's about the only treatment that happens with these.
Okay. Another question that was submitted is, so are there tests which identify physiologic erythrocytosis?
I do not know of that. The only thing that is a physiologic is the P50. I do not know of testing that. The answer to that is I do not know of that. Oh yes, another question. So my father was diagnosed with P. vera about 3 years ago in his 70s. Why did it take so long for symptoms? I'm not sure if he means why. I mean, since this is an acquired thing, that is not rare that someone could have it that late. Remember, the median age is 60 years, so someone having symptomatology in their 70s is not very unusual at all. If I assume that the symptoms didn't show up until then, it's very likely the disease wasn't acquired until that late time.
Thank you for participating in today's specialty testing webinar. If you have additional questions, please indicate them on the evaluation that will be forwarded to you shortly. Note, laboratory credit is extended for this program, so upon finalizing your evaluation, you will have the option to claim credit and print your certificate. As a reminder, this program was recorded and will be archived on our website in a few weeks. Thank you again for joining us. Have a great day.